All right, good afternoon. I am Dr. Shirlitha Lee, Chair of the AACN Program Committee and Dean and Professor of the Mary Black College of Nursing at the University of South Carolina, upstate in Spartanburg, South Carolina. Welcome to the first round of the ANLC Emerging Solutions, leading implementation of the essentials, insights, and lessons learned along the way. Today, we have a panel of academic leaders who have joined us to share key insights and lessons learned along the journey to implementing the AACN essentials. Now, let me introduce the panel of speakers. First, Bim Akintade. Bim, you raise your hand. There you go. Dean of the College of Nursing at East Carolina University in Greenville, North Carolina. Dr. Akintade has engaged in clinical practice as an acute care nurse practitioner in the post-anesthesia care unit and the trauma surgical intensive care units, and he has led the transition of the master's programs to the doctoral level. Second, Dr. Robin Newhouse is Dean and Professor of the School of Nursing at Indiana University in Indianapolis, Indiana. Dr. Newhouse is a scientist, leader, and scholar whose research in healthcare delivery and evidence translation models has improved quality of care and outcomes for patients. And third, Dr. Danny Willis is Dean and Professor of the School of Nursing at St. Louis University in St. Louis, Missouri. Dr. Willis worked throughout his career to champion students and faculty success, advance diversity within the profession, and promote nursing science with a program of research and scholarship focusing on promotion of health, well-being, and healing in the aftermath of marginalizing and traumatic experiences. A full bio for each of our panelists is available on the conference app. There will be time for Q&A after we have heard from all our panelists. I also invite our virtual attendees to post your questions in the virtual platform Q&A box, and I will present those questions for you. So we're going to start by just asking our panelists to share with us a little bit about where they are on the journey to implementing the essentials, and a little bit about your programs as well.
All right, I'll get started. I'm from Indiana University. Okay, just testing the mic here. Testing, 1, 2, okay. Sound better? No, okay.
I'm going to let you borrow mine for a second.
Thank you. Thank you very much. So Indiana University School of Nursing is our campus that is the Academic Health Center campus is in the city of Indianapolis. We're also affiliated with Bloomington, as well as Fort Wayne, and another school, Columbus, will be coming on. So we have a pretty large, I guess, campus, if you will, and a multi-site campus. We have about 2,000 students. Our undergraduate programs has 3 tracks: traditional, accelerated, and RN to BSN. We have 9 masters, and I won't go through each and every one of those. It's complex. 5 are advanced practice nurse, and then leadership and education as well. We have a DNP and a PhD. So it's, as I said, it is a complexity, but I think that I just want to say that our faculty embraced the essentials as an exercise. At Indiana University, we tenure on education, so we have a number of faculty that is their scholarship, that's their research, as well as our clinical faculty often focus on innovation. So when we reviewed our task to implement the essentials, the faculty actually rallied around it very quickly. What has been done to date, actually, all the work was embedded within our governance system so that it wasn't extra work. It was work about improving our curriculum. They all came together and they mapped the curriculum. They identified the gaps. This is for undergraduate and graduate programs. And to date, now we're down to the syllabus level, understanding how those syllabus revisions will occur and the competency-based education that will be happening.
So, who wants to go next?
Oh, wonderful. Mike's work. I'm Bim Akintade once again. I'm Dean and Professor at East Carolina University. Exciting opportunity for me. Our journey and my journey are sort of working in parallel. Up until July 1st of this year, I served as the Associate Dean for the Master's Program at University of Maryland. So as some folks remind me that in my new role, I've been there for only 2 minutes, but it's actually about 3.5 months or so. So I've really immersed myself in not only the community or the culture, but also the College of Nursing. So far, a lot of work has actually occurred at ECU College of Nursing regarding the new essentials. So the work actually started last year, last fall, where the faculty came together, so the leadership and also the department chairs to try to evaluate what the plan of action would be, so to speak. And earlier this year, at the college, they underwent some faculty development exercises, I believe. They had two national renowned experts come by the college to provide some education and direction. And like most colleges across the country, they embarked on mapping the curriculum. So mapping not only the courses, but also the course objectives to the new essentials. That was done in what feels like record time, because just like Robin at IU, we also have an entry into practice program. We have an accelerated BSN program. We have the RN to BSN. We have a master's program, also a DNP with 5 APR enroll programs, and also a DNP. So currently at ECU, we're done mapping the curriculum, and now it's essentially the next step, which is evaluating the gaps and now starting to address those gaps as we align with the CBE model.
So I'm Danny Willis, and I am entering my 3rd year as Dean at St. Louis University. St. Louis University is a Jesuit and Catholic university, and we have over 1,000 students across our programs, 3 pathways in the baccalaureate. We have 6 different programs at the master's level, doctor of nursing practice, as well as PhD. Our faculty, I think, embrace this as well, similar to yours as you were speaking, Robin. I think that what they saw in the new essentials was a path forward that was clear in terms of the knowledge domains that are needed for practice and that our practitioner partners are looking for. That does not mean that there was not some resistance, because there is, and I need to put that out there. I'm very impressed with what the faculty have done with our work. Like Robin and Bim, we are through the course mapping component, really looking at the curriculum from a holistic perspective across all of our programs. One of the things that was really interesting that we were facing as we started this last year is our university was going to a core curriculum for all baccalaureate students. And so integrating these key characteristics across a Jesuit and Catholic education around things such as quantitative reasoning, equity and social inclusion, eloquentia perfecta, being able to speak and to write eloquently and to make points and debate. All of those things were needing to be aligned with our current curriculum, and as you know, it's very prescriptive in terms of nursing curriculum. So we were in that place where we were also having to align what we currently do with the core curriculum and those key domains of knowledge from a core curriculum, as well as with our interprofessional education competencies. And I share that because the work can seem overwhelming, right, to look at the essentials. But yet I want to say people are able to do that because literally we were looking at 3 different approaches that we needed to account for, and the faculty have rallied to do that. And there's more to the story.
Good, thank you for that. So you talked a little bit about faculty being involved in the process, and so I just kind of want to hit on resource allocation. So when faculty were involved, were there committees, task force? How was this work led? And did you need to incorporate any faculty development into that as well? Anyone who wants to answer is fine.
So I can start this round. I mentioned earlier that lots of changes are occurring, and I'm sure these experiences aren't just unique to us. At ECU, lots of organizational changes are also occurring. So for starters, I'm taking over from Dr. Sylvia Brown, who was dean for 14 years and 2 years as interim. So leadership, sustainability over time, that's a big change for our campus. The second thing is our university just merged with Vidant Health to form ECU Health in May. So that's another change we're experiencing. That was actually one of the things that drew me to that university, because significant opportunities for academic practice partnerships. And the third thing is we used to have a health sciences and a vice chancellor model, and we just shifted from that to a one ECU with a provost model. So when you add all these components with the fact that we're coming out of a pandemic and we're sort of transitioning into this endemic state with a new dean who also has, so I'm completely external. I'm from Maryland, spent most of my life in Maryland. I've had the opportunity to do some assessments, shared some during my interview and some that I've had the opportunity to do once I got there. So sharing my strategic vision along with the new essentials has been quite challenging. I have to give the faculty a lot of credit. We're talking about faculty resources, and based on my previous experiences where we had more resources, there aren't many resources here. When I also started July 1st, I think 12 full-time faculty members were either leaving or retiring. So yeah, and the faculty managed to map between spring and summer. The faculty are really excited about this work. They're encouraged. They see this as the future, but also recognizing how I'm sort of encouraging a shared vision as a new dean in terms of our strategic direction, along with the new essentials, does pose a challenge. So now part of my new strategic vision is how to continue to support the faculty, not only long-term in terms of our teaching, research, and service mission, but also just getting through the essentials implementation. So we don't have additional resources dedicated to this. There are no faculty FTEs associated with this. Faculty's doing this in addition to their current responsibilities. And they're doing a fantastic job, I have to say.
Good.
Similarly, I have a lot of kudos for the faculty who've taken this on for all the reasons Ben said as well. I mean, coming out of COVID and aligning with core curriculum, aligning with IPEC competencies, and the structures that we use were the existing structures in the school. I, too, do not have FTE associated with this endeavor, but use the existing extant structure that was there in terms of our undergraduate and pre-licensure program committee and the curriculum revision subcommittee of that, which emerged as a task force as we moved into the space, as well as our advanced nursing practice curriculum committee and program committee. The associate deans have met regularly with the coordinators of the different academic programs within our master's program for nurse practitioner education for our CNL MSN program. We've also had the level 1 and level 2 coordinators of our baccalaureate TBSN or RN to BSN coordinator and our accelerated bachelor's of science and nursing coordinator. They have been really leading the charge to rally the faculty around this, and the existing structure has worked well. It's a service component of the tripartite mission rather than having additional FTE, as I know some places that I'm aware of have allocated for that.
Yeah, and I would say our experience is similar as well, and this really was leadership at multiple levels, in that our executive associate dean is responsible for the academic affairs across all of our campuses, and there is an assistant dean for undergraduate and an assistant dean for graduate. However, it really is the faculty that led this effort, and they led it within the governance system as it's established. So the curriculum committees, the committees that were reviewing syllabi, it was the same structure that was used, so there wasn't an additional effort associated with this. Certainly, we allocated staff to help take minutes and other kinds of things that we do for other committees, but it was pretty typical. And I would say the leadership also is at the level of the course, because now that they've gotten down into some of the details, it's the course leader that is doing that work and making the changes that need to be made that will come back to the curriculum committee for a comprehensive review. So it really is something that happened at the same time we received a large gift to double our undergraduate enrollment. And you'd think, oh my goodness, that's a lot. It is a lot. But what ended up happening is, as part of that gift, the faculty had already divided into a number of committees already. And quite honestly, the essentials are also about improving our curriculum excellence and quality, and curriculum will never be done with this work, truly. So the committees that they established were very much like what we also needed for the essentials.
Awesome. Thank you guys for that. I know many of us as deans are in different places with our programs as far as adopting the essentials, and I commend you guys on being early adopters. So what's driving you? What drove you to be an early adopter?
Well, I talked about our context. And our context is that our faculty scholarship is in the area often of education and either science, pedagogy. They are constantly testing the methods that they use within their courses or evaluating their teaching learning strategies. So it was natural in that if you look at the attributes of your own organization, you know you've got some strengths in different areas where people are just excited and motivated to excel in that area and to engage in that area. And I think that's what happened. They were ready, and it is the kind of thing they see as a challenge, and they work very well together to think collaboratively and wrestle with the tough things, and they always come out with a wonderful product. So it was an easy decision for us. And they said they wanted to, so that was even more important than my vote.
I think very early on, we were thinking about, innovation and the changes that needed to occur, I think, in the way we think about education, and having a long tradition of innovation at St. Louis University School of Nursing. I think it was part of the culture to be thinking about what's the next step, what's the leading edge, and people really adopted it early. And like I said, I think context is so important because we were already going through these other change mechanisms or transformation mechanisms. It was just a time for us to really look at everything together. So I think that was a huge driver and continues to be.
And same for us at ECU College of Nursing. Fun fact, the school graduates the largest number of entry into practice nurses in the state. And over the last 6 years, our admission numbers has grown by about 50 to 60%. So we've seen just accelerated growth over time, including the addition of some of our advanced practice programs. And so there's always been a desire to revise our curriculum. At the entry to practice level, we hadn't revised our curriculum since 2003. And I recognize that's a long time. But with the conceptual idea that the new essentials would be released, there was an intended or an intentional decision to kind of wait to align with that. So even probably before its release, we'd started working on that. So once again, opportunity for innovation, opportunity for research and scholarship to continue to elevate the university in terms of its position in the state and also in neighboring states. So the faculty have been all over it from day one.
And one of the, I think my mic is off. One of the reasons for incorporating the essentials is to kind of close the gap between practice and education. So are you guys incorporating your practice partners into the process, and if so, how?
I can start. Actually, our Executive Associate Dean of Academic Affairs held a AACN event with one of our major partners that shares our name, ECU Health, and we have many partners, but they're the one that they have a very large system, and many of our clinical sites are at ECU Health. So they brought the leaders together from Indiana University and the health system to just dream about what we could do differently together. And that created a number of themes, and a number of themes that indicated what we could do for a clinical partner. For example, one of the examples were about leadership development. We have a very strong leadership development curriculum and a master's in nursing administration, so that's something we could do for them. So we talked about what we could do together, and we're coming up with a plan as the next step. But the other thing will be that they will be more embedded in the conversations about the academic curriculum, which will be more than welcome. And I'd say that as part of this, we've also agreed to come together, both at the leadership at the health center and the academic center, to map out some of the requirements that maybe we're missing. They hire a lot of graduates from Indiana University. They know what they need when they come into clinical practice, and it'll strengthen our curriculum. So that's how we'll embed it, and we'll embed it with them in a way that's purposeful based on the themes that develop from the AACN event.
So I think for us, I mean, this is it's a natural evolution. We have advisory board meetings with our clinical partners, and so this occurs at least once a year. But one of my strategic priorities for ECU is academic practice partnerships, because we have significant challenges in the area of nursing workforce development. So we've had several roundtable discussions, and we've also recognized that having our practice partners be part of that conversation early sort of makes them stakeholders. ECU Health, with the new merger, is our biggest clinical partner. And so as part of this academic practice partnership, they are actually, members. They sit on that initiative. In addition to CBE and how that impacts our curriculum, our vision is that they would also have clinical-based objectives, that sort of takes into account our curriculum, and that may help expedite our nurses' transition from academic to clinical practice. So they're at the table, and their contribution is valuable. So hopefully there should be no surprises at the end of this process.
So similarly, can you hear me? Similarly, our biggest healthcare partner is SSM Health, which is Sisters of St. Mary Health. And so we have started conversations with them. We have an academic practice partnership that we started just this past year with Cardinal Glennon, which is a member of the Sisters of St. Mary system. However, there are other aspects of our clinical partnerships that we have not yet started those conversations with, and that will be an evolution that will occur as we move forward to get more involvement from a wider swath of our clinical partners. But at the moment, it's been really limited to the SSM system.
So I'm going to tie this next question into one. I want to know about some of the challenges you face, because we know anytime we roll out a new process, it doesn't always go as smoothly as we plan. So any challenges you face, but also I want to hear about your big wins, your successes. So tell me a little bit about those.
So I can start. So challenges, I feel obviously, as we probably are aligned with many other schools and colleges of nursing, faculty shortages, staff shortages, additional resources to include labs, simulation, clinical partnerships in terms of clinical placements for students. But from my perspective, I think some additional unique challenges include my strategic vision and how that aligns with everything else happening, because it's my belief that we can do everything right now while we're modifying or revising the curriculum. And I'll give you a couple of examples. So One of the major gaps for us in terms of APRN programs is we don't have an adult geriatric care NP program. I'm an adult geriatric care NP, but I'm not showing my bias. Based on our mission, that's a significant gap in the care of the region. And so this is a great time to start one of those. So hopefully that'll be an outcome from our academic practice partnership with our major healthcare partner. In addition to that, there are opportunities for co-curricular collaborations. So anyone who's involved in a national conversation recognizes the opportunity for nurse leaders to have more healthcare finance and healthcare economic, knowledge and expertise. So I see an opportunity where I also have an MBA, not biased, but I see an opportunity where we could collaborate with our College of Business to offer MSN MBA dual degrees, and we've started those conversations. So it's a matter of balance. How do we balance while we're in this space and we're reevaluating our curriculum? How do we balance our resource availability along with the vision and just trying to roll this out one time and not go through this now and then in a couple of years we recognize there was an opportunity to do certain things. We're still facing a tremendous shortage. And according to the literature, over 50% of nurses are age 51 and older. So for ECU, if you ask me, one of the things that keeps me up at night is succession planning, and just recognizing how we not replace, but how we plan for the future. We have a 97% NCLEX pass rate, and that is so amazing. But the way we accomplish it is a lot of physical manpower. Behind the scenes, a lot of one-on-ones with students. I can tell you it's almost unsustainable looking at the future, So how thinking about next gen and sort of maintaining excellence, over time with these changes, and also with the new vision, for increased research and scholarship and DEI. These co-curricular collaborations, it requires more leadership opportunities, and those are conversations we're having, but we don't have a lot of resources to kind of support that process. So those are some of the conceptual and operational challenges that we're facing. Nothing to do with the essentials themselves.
I would agree, and one thing I think about is nurse, faculty, and staff well-being. I think about that a lot, and I do think that's one of the major challenges that we face. I mean, we've seen through this COVID pandemic, at least in my setting, I don't talk to others, and I don't think it's unique, with the stress that the students have been through, right? There's more stress upon the faculty, there's more stress upon the staff. We know COVID has resulted, at least in some instances, our staff numbers being decreased, and they might have already been slim. So I think in terms of, while we're talking about the essentials, if we think about this larger context in which we exist and how we do our work, I think those are some real challenges for us. So I think having work around promoting faculty well-being and staff well-being is really essential in a way that I think we have to really put a lot of thinking and resources into as we move forward.
And I would say, I won't disagree with one thing that you said, but I would say that one of the challenges for us with the essentials was more in the graduate program than the undergraduate program. The undergraduate program, the governance structure was working together from all of our campuses. Our graduate program is primarily in Indianapolis, but each one of the courses were so different for our advanced practice, our clinical nurse specialist, and other masters that it's taking a lot of work to figure out how to embed the essentials at the level 2. So it's taking them a little more time because it's a little more complex and it wasn't so easy as a unified curriculum in the master's program. And the good thing that happened is just some innovation, and the faculty were thinking very differently about how to teach and learn. And one of the faculty, Rebecca Ellis, developed a harm reduction initiative whereby instead of assigning a student to one patient and they stay with the patient for the whole day, she had a group of students, 8 or 10, and she actually did safety rounds for the hospital. She developed an algorithm and had an app on her phone that the students actually assessed each patient for a number of safety risks and nurse-sensitive indicators. And at the end of the day, the nurses in the debrief had such an appreciation for the holistic implications and impact of nurses even after one day. It was incredible the number of identified harms that could happen that they prevented. So at the end of the day, they actually could see a dashboard to say what they did and what interventions they did as students. So it was a very different trial, but it happened because faculty are trying to think about how we could do this differently. And it's not clinical as it was.
Yeah.
Well, I think that's a good lead-in to ask to my next question, because when we talk about the new essentials, a lot of the direction is moving us away from just thinking about acute care when we think about clinical practice. So how are you incorporating the 4 spheres of care into all of your clinical hours that you're incorporating as you're rolling out the new essentials?
So we've had discussions about the 4 spheres of care. In fact, it's one of the areas that we're really focused on at the moment, is to think about that for our undergraduate education space and what that actually means. And we were just prior to coming into this session, we were having a session with Susan Corbridge sitting here in front of us around different ideas. And one of the things that emerged was thinking about, it's not necessarily that you have to have these 4 distinct clinical areas. But if you think about a patient across the course of the trajectory of their health and illness situation, that there are opportunities perhaps to see that, right? It doesn't necessarily mean that you have to have these 4 distinct kind of clinical sites. But one of the things we're doing, though, which is similar to thinking about distinct sites, is really mapping all of our clinical partners and the types of services that are provided in those spaces. So it's a way to get a comprehensive accounting of what is actually offered in the spaces that we're currently in. And from that, there's also this piece of, you mentioned going back to the courses and looking at the syllabi and those types of things, but really thinking about how we're positioning ourselves and how we're thinking about in these various courses, those 4 spheres of care. And do all 4 fit? So if you have a course in community health, right, it's clear that that's going to be about health promotion and disease prevention. It could also be clear that it's going to be about chronic disease management. It can also be that palliative and supportive can be there. So I think it's beginning to think about, how to integrate, I guess would be the word, those ideas across each course. And then, of course, in terms of how that's mirrored experientially, how that's mirrored through simulation, how that's mirrored through the didactic and the theoretical content.
So I actually appreciate that thought process and recommendation in terms of, in addition to mapping, identifying what types of experiences students get. For us, so far, just as you mentioned, in the entry into practice space, it's really challenging to sort of tease out those specific experiences. So for now, we just ensure that our students are experiencing those 4 spheres, sometimes within the continuum of care of one patient or in a certain clinical space. Moving forward, there has been some conversation about how we intentionally get that level of specific care, be it acute care, preventive, care, hospice. But one of the other things that we're thinking about, and I know there's also a national conversation about this in terms of behavioral care and community health, is to try to weave that throughout the curriculum. So as for today, we're still in conversation in terms of how we would approach that.
Yeah, and just two things. First of all, this is the most person-centered approach to teaching and learning that I've heard about, frankly. And that's all about who we are as nurses, is to honor the person who has multiple experience over their lifespan and their families. So there's an exposure and appreciation in these spheres for holistic nursing care. So with that, though, does take some, the typical coordination and clinical placement and assuring that we're talking about the right things and we're framing it a little way. This is a conceptual shift, and yet we've been there our whole lives.
Thank you. I was going to ask you guys too, as you've been rolling out the essentials, you know, AACN provides quite a bit of resources available on the website, toolkits, etc. Have you used any of those resources that they have available? Which ones have you found most useful? And are there any others that you would need or would like to see?
The crosswalks are really wonderful. Our graduate advanced nursing practice program committee has really used that, and it's been really helpful. I love the curriculum mapping tools that were provided. That's also been very helpful. So I do think that the resources, the webinars, we just had this excellent webinar that you all provided with Don Mueller-Burke from University of Maryland, Baltimore, which was great. We have others coming up from AACN, so I think, yes, definitely the resources are helpful. I think in terms of what's needed, I'm not sure yet, but I do believe that, at least from the discussions that we're having, really understanding more deeply. I mean, we understand, but I'm not sure we understand deeply what this multiple assessment process and it's developmental and it's transformational and it's interactive, all those components of a CPE model really look like in its most robust form. And
same here. I believe the toolkit has been very, very helpful for us. The webinars have been essential. Last night, while I was preparing for this talk, I realized that the repository is live on AACN, and it's, if you envision a service like Up to Date, where you could go in and actually research certain essentials, and it sort of spits out lots of resources you can identify with. So I thought that was very helpful. Other things that we're doing that's helping out is communicating with other deans and other schools just to try to see where everyone else is. If nothing, I think that makes you feel better about yourself, you know. But obviously, I mean, we've learned a lot from each other. And in my experience, it's funny you just mentioned Don Mueller-Burke. While I was at Maryland, Don and I co-led the Essentials implementation at Maryland. I'm also pretty active with AACN. I sit on the Essentials Implementation Steering Committee, and I'm also chairing the Assessment Expert Work Group. And as a new dean, I was sort of trying to figure out how I could walk the line between provide guidance to my college, my new college, also understanding that the curriculum belongs to the faculty. So I spent about the last 3 months sort of gaining some insight in terms of where we were, and in my one-on-ones with the faculty, I got a sense, and just like many other places, you really could even be siloed unintentionally even within each school. The faculty are doing a tremendous job. Our Associate Dean for Academic Affairs, Annette Perry, has done a great job in that space, working with the chairs. And so I met with the chairs and just presented some potential models that we could adopt as a college. Wasn't a way, or it wasn't providing direction, but just providing information and some guidance. And that has worked very, very well. That was couched, obviously, with the fact that AACN wants member schools to identify champions. And for us, my one ask was that the champion was a faculty member, not an administrator. And so in a really short period of time, we were able to identify a faculty lead, and the Associate Dean for Academic Affairs would serve as a co-lead. And it's clear that she's in a resource and supportive role, but the faculty would take the lead. And we've identified faculty leads for levels 1 and 2 and for some of our different programs. And in a short period of time, we have a model that'll be rolling out probably at the end of this year or early spring. So what else do we need as faculty? Just, I think I mentioned this earlier to Susan, an opportunity to bring those champions together outside of the deans, just so they have an opportunity to ask questions directly and get the support they need.
Yeah, our experience was similar. Our faculty accessed everything. It was very easily accessible. They appreciated the responsiveness of AACN when they were called. They participated in webinars. They did a webinar for AACN. So it was a wonderful, wonderful resource. And some of you may have helped to develop those resources. So I should say it's, I think, a wonderful exercise for us as deans to be able to be involved in those kinds of things. But as time goes on and we develop and become more mature in this journey, it will be good to have the ability for our faculty to be able to submit some of the resources that they're developing if they'd like to share them. So we ought to have some kind of shared opportunity where I guess the reference would go back to the faculty as a scholarly product, because this is going to take a while and it's going to take a lot of us to think very differently and could end up with some interesting resources.
Good. So we have a room full of leaders, and we know as leaders we're easily motivated. So if we all want to go back home today and get started on this, what would you recommend we begin? Where should we start?
So I can start. Once again, I feel like I have a unique perspective. I went from a relatively large R1 research university to a more medium size. We have between 13 and 1,400 students at ECU. And while I was at Maryland, working with my colleague who was the Associate Dean for the Baccalaureate program, Dr. Maeve Howard, we were in full steam ahead. Maryland implemented the new essentials in the baccalaureate program this fall. And I've transitioned to another university that doesn't have as much resources, with several, competing efforts, and so the one thing I'll say is just, one, assess where you are, understand exactly what resources you have, identify your champions within the organization. Like I said to the faculty after we had this conversation, it's led now to this faculty-led model. I'm going to do two things. One, I'm going to stay out the way, and two, I'll be available as a resource if you need me. And that's kind of our approach.
Yeah, I would say the same. Take stock of where you are. The assessment piece, I think, is really huge in terms of where you are at the moment. Think about what resources you need. Think about structure, process, and outcomes. Very simple way to have a framework to think about where you go. I'm sure everyone's in different places, and take stock of that, and then reach out for help. I really like the idea of sharing, as you mentioned, sharing among us, right? Having conversations with your colleagues and having those champions who are really going to lead the process. And deans are there to support and to offer resources as possible, but it's really faculty-led, faculty-driven.
And to also celebrate the faculty.
And I would say, think about using some conceptual model for implementation, because it'll help us think, it always helps me think about what things I may be missing. So when I think, I typically use the Greenhall model, which is about really innovations and how they diffuse in healthcare, but it really works for us too, because it reminds us that we need the resources and we need the change champions, But then we walk through this process where we understand the antecedents or the characteristics of our organization, those strengths that we talked about, our weaknesses that we could have had more. Then it goes through the readiness, how you get an organization ready to launch this kind of work. And then once you're ready, there's this period of adoption. So you're going to make a decision, or our faculty or our students are going to make a decision to use this evidence, the essentials in this example. And once we make a decision that we're actually going to use it, the next are the implementation. It's all the things we're doing right now, but you need to get your context ready to begin this kind of really hardy work. And then after you have an implementation plan using a number of implementation strategies, you're going to get results or the consequences, which we'll need to set up some kind of metric or measurement plan about how these changes made a difference to our students. So that's the short version of that, but it is very helpful to think in a very systematic way about how we do this, and using a conceptual model like that always reminds me, slow down and get ready. If we're not ready, how are we going to get ready? We're going to watch these webinars. We're going to bring in a speaker. Maybe we'll bring in a consultant. We're going to review the essential material on the AACN website. So that is just one strategy I would suggest if you haven't started yet.
So we have about 10 minutes left, and I really want to make sure those of you who are here with us today in the audience and also virtually have an opportunity to ask questions if you'd like. There's a microphone to my far right as well as to my left. If anyone in the audience has a question, please feel free to go to the mic. And in the meantime, I do have on my iPad, I can see questions from the virtual audience. So I'll go ahead and ask one from the audience. And so one of the questions from the audience is, how do you get senior faculty on board for changes in the essentials? As they say, if it's not broke, don't fix it.
Yeah, I would say that in my group, it is a we, not a they. And you can engage mightily, and there's some that won't engage as mightily. They want to wait and see the product. And that's okay too. This is a change that's going to happen. Embrace everybody you possibly can and bring them on board to the extent that they want to be involved and give them a voice in this. We're people. We're systems. These are the kinds of things that we as leaders have to observe and help. But I'd say we all have a common goal. We want to make sure our students are successful, they have a context of learning where they're safe, and they're ready to be registered nurses when they graduate from our program. So we all have that same goal.
I like to emphasize lifelong learning. I mean, that there's this process that we're in for people who may be more resistant, but this lifelong learning process is an opportunity. It's a great opportunity to expand and to evolve the way we're doing things. And I think, at the end of the day, it's really, how are our students more prepared to be practice ready? And how are you contributing to that? What knowledge are you bringing to that? What energy are you bringing to that? And what types of structure are you bringing to that? I think is really important to get people engaged. And as Robin said, some will be mighty and some will not be so mighty in terms of that process. And that is how it is.
And just hearing that, the only thing I'll add is it strikes me as an opportunity to educate and reinforce why we're doing what we're doing.
Another question from the virtual audience, since no one in the room has a question yet, is for a small college, one AACN program with limited resources, what would you recommend for ensuring this transition is completed effectively and efficiently? We have a small faculty. How do you allocate resources?
So I don't think there's a magic bullet. I don't think there's a one-size-fits-all answer to that. Once again, we're all very unique in how we're built and how our funding models work as colleges and universities, as I am finding out in my new role. But I think just like anything else, for a small college taking this on, I think just aligning with academic partners may be helpful for them, because you may be able to share resources with other organizations. We conceptualize that with academic practice partnerships. I mean, there's no reason why we conceptualize that with other academic organizations. I think AACN also has been a fantastic partner and a resource center through this process. I mean, other than understanding what the unique challenges are, I think those are a couple opportunities.
Yeah, I'm wondering if that's a question that should come up at the Like Schools meeting, because, we probably have all been part of consortiums before, and they don't have to be formal consortiums, and sometimes partnering with others that have similar kinds of schools can really result in some great advances and partnerships.
Yeah.
Okay, any questions in the audience yet? Okay, so I'll go with virtual questions again. The next one is, how are you integrating the 500 practice hours into your revised master's programs?
Yeah.
That's mapping. It's back to that same principle. It's mapping and integrating it, and there's no other way to do it that I'm aware of.
And for us, I mean, we're still conceptual. We haven't got to the point where we're completely addressing the gaps, but I know there's several conversations surrounding how we envision that. Another thought process is, there are experiential learning opportunities that we haven't necessarily counted or quantified, so now we just have to be a little more intentional as we conceptualize that part.
Still no questions in the room yet, so I have another virtual question. And they want to know, oh, there is, great, go right ahead, thank you.
Is this on? Yeah. My name's Neil McNaughton. I'm at the University of Dubuque. It's a small liberal arts college, similar to what the previous question had. Many of us do not have the resources, nor do we have the ability to also partner with schools in our areas, because we're in direct competition for the limited number of students. I am concerned that you want us to bring that to just the small groups, the small college programs, breakout session. My concern is that this is an issue for almost 50%, 28% of AACN. And while I appreciate you all and giving us what you've been doing, for those of us in small schools, I do not have the resources of associate deans. I don't have the resources of even more than one other PhD in my department to work on this. So I think you're making, AACN needs to start addressing the fact that a quarter of the population of schools do not have the resources that the large academic centers do. And I'm kind of tired of not hearing about how some of us are affected. And I think it's time that AACN step up to the plate.
Thank you for that comment. Does anyone have a response or want to make a response?
Thank you for your comment, for bringing that to the forefront of the discussion. I don't have an answer. I think that, but it's an important component for us to look at.
And also, I see Susan and Jonah Wright taking notes, and I expect that to come up in some of our committee work to try to address. I mean, I also hear and empathize. I don't have any further recommendations.
I see we have one last question. Julie?
Hi, good afternoon. Thank you for your presentation. I'm Julie Hoff from the University of Oklahoma. Robin, I loved what you brought up about a change in clinical, one innovation in clinical. I would be curious where you are in the process. How do you see your curriculum changing as a result of this? One of the things that I'm struggling with is we've mapped it all out, there still is no room for any electives. And I'm just like, they need big data, they need finance. I mean, there's so many other things that we should be introducing them to. And I would be curious what your experience is, if you've been able to kind of change your curriculum and be offering more than just the typical what we do in nursing.
And this is hot off the press, so this was not something that that has been tested. It was just implemented. I think we're going to see more of those, actually, and more ways of considering how clinical might look a little bit different for our students, to give them a little more breadth of the implications, not just to the patient, but how the system's role in improving the health of the patient is important. I think this is going to be a journey. I think I'll see more of this kind of innovation, but we're not there yet. This just really started. Mm-hmm. I wish I had an end point, could tell you wonderful things, but so far, it's an N of one.
Well, I want to thank everyone for joining us for this session. Please give our panelists a round of applause.